Welcome to the Kuala Lumpur International Conference on Education, Economics and Technology, 2026. I'm honored to present Exploratory Pattern Analysis for Ambulance Dispatch Time in Greater Kuala Lumpur. This study examines ambulance dispatch patterns across Greater Kuala Lumpur, analyzing response times, geographic variability, and factors influencing timely emergency medical service delivery in urban and suburban settings. We focus on the Hotspot Initiative, a collaborative effort between the Malaysian Red Crescent Society and Kementerian Kesihatan Malaysia, to proactively position resources where emergency demand is highest. Through data-driven insights, this research aims to optimize dispatch strategies, reduce critical response delays, and ultimately strengthen emergency care resilience for communities across Greater Kuala Lumpur. Thank you. In Greater Kuala Lumpur, these emergency response challenges become especially acute. High population density, chronic traffic congestion, rapid urban expansion, and complex land use patterns all combine to slow critical ambulance access. As the nation's primary economic and administrative hub, Greater Kuala Lumpur sees intense daily mobility, frequent traffic bottlenecks, and highly varied neighborhood structures, creating a uniquely complex operating environment for emergency services. These urban dynamics contribute to spatial and temporal variability in how quickly ambulances can be dispatched and reach patients, depending on location and time of day. Between 2017 and 2021, Malaysia's MERS 999 hotline received 61.4 million emergency calls. Yet fewer than 1 in 10 were verified as genuine emergencies. The 5.4 million validated emergency calls were routed to key agencies, including Kementerian Kesihatan Malaysia, Angkatan Pertahanan Awam Malaysia, Jabatan Bomba dan Penyelamat Malaysia, and the Malaysian Red Crescent Society. Of these, out of this number, Kementerian Kesihatan Malaysia only received a total of 2.07 million emergency calls. Just 1.06 million were categorized as Priority 1 emergencies, refer Table 1, requiring immediate stabilization for critical conditions such as stroke and traumatic injuries. However, the audit report offers no specific details on how Angkatan Pertahanan Awam Malaysia and Jabatan Bomba dan Penyelamat Malaysia managed emergency cases involving ambulance transportation. Emergency medical services are the front line of modern healthcare, delivering rapid, expert medical care the moment someone faces a life-threatening emergency, when every second truly counts. The golden hour is the critical 60 minutes after a traumatic injury, where swift medical intervention can save lives and significantly reduce the severity of injuries. Kementerian Kesihatan Malaysia mandates a 50% of response rate within 15 minutes of Priority 1 emergency call ES/must receive a response. As Figure 1 shows, this standard ensures maximizing the impact of the critical golden hour, a real, life-saving opportunity for recovery. Between 2017 and 2021, the actual ambulance response rates at key government hospitals in Malaysia, from Putrajaya to Kuching, Tau, and Miri, ranged from 10% to 46%. Nationally, the actual rates ranged between 32% and 42%. Tau Hospital and Hospital Umum Sarawak, Kuching served extensive coverage areas, suggesting geographical coverage, resource distribution, and operation factors may influence ambulance response performance. Hospital Putrajaya achieved the Kementerian Kesihatan Malaysia response time target in 2017, however, sustaining this level of performance proved challenging in subsequent years. These variations underscore the importance of further investigation to support continuous service improvement. Step 1. Collect secondary data relating to the Puchong and Bandar Kinrara Hotspot Initiative undertaken by Malaysian Red Crescent Society with Kementerian Kesihatan Malaysia on Priority 1 emergency calls received from MERS 999. Between January 1, 2022 and December 31, 2024, 9 primary variables were carefully selected and organized into 3 core categories: spatial, temporal, and environmental factors, including time of day, day of week, public holiday, geographical distance, and weather conditions. To maintain clear interpretability of time-based patterns, categorical variables were applied targeted encoding techniques, preserving distinctive seasonal trends. Meanwhile, continuous variables were standardized using scaling, allowing every input to contribute equally. Dispatch times followed a right-skewed pattern. The mean of 20.2 minutes and the median of 17 minutes both exceed the 15-minute benchmark mandated by Kementerian Kesehatan Malaysia. This aligns with the Auditor General's 2021 report on target non-compliance. The observed skewness aligned with international EMS research, which reported asymmetric dispatch distributions. This skewness, characterized by long tail of a few outliers, has significantly influenced the mean, but not the median. There were incidents where the dispatch time takes 47 to 50 minutes. A Shapiro-Wilk normality test was performed and the corresponding p-value is below the conventional significance level of 0.05 cutoff. The null hypothesis of a normal distribution was formally rejected. This study addressed the non-normal distribution of dispatch time by applying a square root transformation, which is an initial, practical step to improve data symmetry. The transformation reduced visual skewness, and the gap between the mean of 4.4 minutes and the median of 4.1 minutes narrowed. Yet the Shapiro-Wilk normality test produced a p-value of 0.0176, below the conventional 0.05 cutoff, suggesting the transformed data still deviated from normality. In short, while the square root transformation meaningfully improved the distribution's shape, it underscores a known limitation, where basic transformations often fall short for highly skewed time-to-event data, pointing to the need for more robust modeling approaches. Time of day directly impacts ambulance dispatch times. The evening period, which is between 5:00 p.m. and 11:59 p.m., see the window of the highest frequency of Priority 1 emergencies. This pattern aligns with peak road congestion after work hours, which has prolonged ambulance dispatch times. The window of the second highest frequency of Priority 1 emergencies is the morning period, which is between 7:00 a.m. and 11:59 a.m. A 24-hour view shows distinct peaks at 10 a.m. and 10 p.m., each 11% of daily Priority 1 emergencies, with a secondary peak at 11 p.m. These peaks clearly mirror human behavioral movement patterns during business hour in the morning period and social or after-hours activity at night. Recognizing these temporal trends is essential to optimizing resource deployment and reliably meeting critical response targets. Weekly demand showed distinct temporal patterns. As Figure 6 highlights, Fridays and Saturdays accounted for the highest frequency of Priority 1 emergencies, each representing 20% of all weekly cases. This trend suggests a potential association between weekend social activities and increased frequency of Priority 1 emergencies. Conversely, the lowest frequency of Priority 1 emergencies were recorded midweek, particularly on Tuesdays and Wednesdays. Increased frequency of Priority 1 emergencies on Fridays and Saturdays may strain system capacity, potentially prolonging dispatch durations beyond the 15-minute response threshold. This aligns with regional EMS research linking weekends to higher trauma volumes. Figure 8 indicated that only 7% of Priority 1 emergencies occurred on public holidays, with the remaining 93% occurred on regular days. This isn't a holiday spike, it's a systemic, everyday operational challenge. This means that solutions can't be ad hoc. Strategic focus should prioritize sustainable, system-wide improvements, such as strategically adding new EMS stations rather than short-term fixes applied only during public holidays. Figure 8b reinforces this finding, where Priority 1 emergencies distribute almost consistently, with a 40% to 60% split between school holidays and term time. School holidays moderately influence dispatch time, but they're not the primary factor behind not meeting the target mandated by Kementerian Kesehatan Malaysia of dispatching 50% of Priority 1 ambulances within 15 minutes. Lasting progress demands system-wide investment rather than seasonal adjustments. The median Euclidean distance from the EMS station at Masjid Al-Ihsan Bandar Kinrara to incident location was 3.6 km. The mean Euclidean distance was 4.2 km, influenced by several long-distance outliers. The large spatial variance of 9.3 kilometer range and a coefficient of variation of 47% suggests unequal coverage. This study recommends spatial clustering Puchong and Bandar Kinrara to improve dispatch efficiency, acknowledging that Euclidean distance may oversimplify actual road networks. Rainfall served as proxy indicator of adverse driving conditions, although matching localized data to incidents was challenging. For Priority 1 emergencies, the median rainfall duration is 11 minutes per hour and median rainfall amount is 3.2 milliliter. The high variability of rainfall duration and rainfall amount from brief showers to heavy downpours reflects tropical rainfall patterns and significantly impacts traffic conditions during ambulance dispatch to incident location. In conclusion, this study provides objective, empirical evidence that ambulance dispatch times across Greater Kuala Lumpur are significantly influenced by temporal, spatial, and environmental factors including weekdays, travel distance, traffic congestion, and rainfall. Peak hour and citywide traffic constraints compound these delays, resulting in failure to meet the 15-minute targets mandated by Kementerian Kesehatan Malaysia. Spatial analysis identifies recurring delay clusters, indicating that current ambulance depot location and fleet distribution aren't optimally aligned with actual Priority 1 emergency demand patterns across the region. Ultimately, improving urban EMS requires integrated operational, infrastructural, and policy-level solutions. Future work should expand geographically, leverage real-time data, and evaluate cost-effective strategies for sustainable, equitable emergency response across Malaysia. On behalf of the research team, the author would like to express sincere gratitude to the Malaysian Red Crescent Society, who have contributed both directly and indirectly to this study. Your help is deeply appreciated by the team. We would also like to extend our appreciation to the Malaysia Institute of Transport and the Faculty of Computer and Mathematical Sciences at Universiti Teknologi Shah Alam. Your dedication and partnership have been instrumental in making this work possible.